join us.
Awesome. Thank you so much, Sonia. So to start our echo session today, we are fortunate to have Kirsten here. She is a nurse practitioner out of Stanford, Children's Hospital, Stanford, California. And with that, let me share my screen. And now I pulled up too many things and now my screen is hiding. Okay. Everyone can see okay? Oops, let me move this out of the way. All right, Kirsten, you're all set.
Okay, thanks. First of all, thanks for letting me present today. And let's see here. So I have a 21-year-old female with sickle beta 0. She was last hospitalized on the 9th of August. And that was because she had another episode of dizziness and actually fell after her apheresis. So she got admitted for workup and evaluation. She has chronic pain. 5 of 10 is her baseline of her right leg. She also has menstrual cramps that cause a fair bit of trouble for her. Home medications, supportive care, lidocaine patch, and then pain management with gabapentin, Dilaudid, ibuprofen. Has used oxycodone in the past. Continues to use it very intermittently. It does cause some dizziness for her. Another sort of supportive medicines. She is on the same medications inpatient when she was admitted as she is when she's outpatient. She had no IV pain meds with her last admission. She's on a good, has multi, so Miralaxana, milk of magnesia for constipation. Past medical history significant for stroke at age 6 and 12. She has right-sided hemiparesis after her stroke. Actually, after her second stroke, I think she was still able to walk after her first stroke. In 2020, she started hydroxyurea. In 2023, she started red cell exchange. We found this on her labs when she first presented in 2020. She has gallstones. She has right hip AVN, which may be contributing to her right leg pain. She also has dysmenorrhea. No overt psychiatric history. Or no diagnosed psychiatric history. I suspect she has depression related to her inability to use her right side. She's not happy with how her arm looks after the stroke, and is really troubled why apheresis hasn't fixed it. Vital signs after her, this is her admission follow-up visit. She does run a slightly low blood pressure. Otherwise, her vitals are normal. Here are her pre-apheresis labs on the 7th, apheresis, post-apheresis labs, and then once she was admitted. So her hemoglobin was stable. She typically comes in around 9, leaves around 10. Platelets go down during apheresis and pop back up afterwards, and gradually until she comes in for her next one as expected. Obviously, the MCV changes with apheresis. Other labs, her renal function, we check her annual her ACR in January, which isn't on here, but these are her more recent renal function. Creatinine's been stable. Bilirubin is on here somewhere. Here we go. Has been normal. Well, it generally comes in as normal and then leaves a little low after apheresis, again as expected. And then we have what we have on here. So these are the ISTAT results from these were obtained after her apheresis. Now, originally these were reported to be during her apheresis, but these are afterwards. You can see some of her levels are low. And I think this might be part of what's contributing, but I don't know why these happen. And I don't know how they happen on other patients who have apheresis. She's the only one that we have checked them on. Other people don't tend to have problems. She has a history of stroke, as I mentioned. We can see that on her head CT, head MRI. It's unclear whether it was, let me see here. Embolic, or I think that was the evaluation by neurology. They didn't know historically if this was from a
Prior.
yeah, this is definitely from her stroke when she was younger. Social history. She came to California from Zambia, from a refugee camp in Zambia. She lives in an apartment with her mom, 2 adult sisters. Dad and brother have not done well with the transition to the United States and no longer live with her. They were very loosely connected in the first place, so she's actually happy about that. They have a history of violence and abuse. Family speaks Swahili, a dialect. Mom accepts an interpreter. The patient refuses. Patient has had no formal schooling until arriving in California, started in high school. And then because she came in around 17, she pretty much almost immediately transitioned to a continuation school where she's in an ESL program. She's involved with her church, transportation. She has Uber or Caravan for visits, hospital related issues. She takes a city bus to school. She had 1 year of niche support. That's the novel interventions for childhood health. She had a one-on-one mentor for a year, and now has graduated from that, but receives as needed support. Basically, if she calls them, they will help her. What's made her case or her care especially challenging is issues related to her stroke. Her developmental age is probably more like 12 instead of 20. Her birth certificate was had a mistake in it, so her birth year in our system matches that, but that doesn't match reality. So she's actually a little younger by a couple of years than her birthday indicates. So she's, instead of 20, she might be 19. Instead of 21, she might be 19. Issues related to language and time. Did you take this yesterday? Did you take this before or after? All of those things are really complicated. We haven't figured out a good way to actually establish those kinds of things, despite many attempts. She's fiercely independent and will not allow her family to be involved at all in her care, or allow us to access her family for supporting her care. So those are the social things and history things that are complicated. But my main question is, what is it with apheresis? Why does she have so much dizziness? Now, in doing this workup, I realized that she has had episodes of dizziness before apheresis, but they've certainly gotten much worse. She said she's had 5 in her life from when she was young, but now they happen on a monthly basis with her apheresis. They did not happen in the beginning. When we first started, probably, I don't know, 6 to 9 months in, maybe a year in, they started happening. We've made a lot of changes to try and help her not have these episodes. We removed her pre-medications, her Benadryl and her oxycodone that she sometimes got depending on the nurse. We asked that the same apheresis nurse come every time and manage her treatment, so that we can have more control over the speed, the medicine she gets, and of the procedure itself. We have make sure that if she hasn't eaten at home before she comes in, that she has breakfast. has something to drink, and then afterwards that she gets up slowly, changes position slowly, to help with her orthostatic hypotension symptoms.
Cool. So just to summarize the case, and then we can open up the floor for anybody with clarifying questions or suggestions. This is a 21-year-old female with sickle beta thalassemia 0 who seems like she's getting admitted frequently after red cell exchanges for dizziness. She does have history of 2 strokes, second one leaving her with hemiparesis. She has AVN of her right hip, suspected depression just based on the functional status and her appearance. And the main question is really the dizziness. So I have questions, but I want to open up the floor because I'm great at hijacking conversations. So if anybody wants to ask any clarifying questions or feedback, I'll open up the floor before I chime in. You're making me chime in. I'm just kidding. So it sounds like what you were describing, these are isolated episodes only around the red cell exchanges. She doesn't complain of dizziness necessarily during the day-to-day, because anyone with dizziness, I always want to just rule out potential inner ear. So are you noticing the dizziness with rapid head movements? Are you noticing it with position changes, or is it strictly with the red cell exchanges? Because based on that response would kind of put my mind in a different lane depending if it's red cell exchange.
Yeah, it's really apheresis.
So I have one patient on apheresis who had a similar presentation. The only difference is it was since she transitions and we started her. So I think it's different for you since it sounds like she was on the exchanges for a period of time and then something changed in that year or so where now all of a sudden she's continuing with the dizziness. So I would be interested in any medications or supplements that she might have taken that morning. Is she eating breakfast? What's her hydration status? Because this one patient of mine who ever since we started her on exchanges and was having these orthostatics, I bolus her with 500 cc of fluid with each exchange. And that was the Band-Aid that fixed it. And she hasn't had a single episode since then. I love the idea of having a single nurse so you can rule out any, oh my God, I'm blanking on the research term, something variability.
The provider variability.
Thank you.
Yeah, that helped
So I think that was a good
bit.
idea. So at least that way you can control that factor and make sure that if she still is having it, it's not a matter of how it's accessed, the flow, the rate, etc. That I would inquire further of like, what's her morning like before coming into the exchanges? Is she having any like fears or subconscious manifestations that could be causing some stressors surrounding the exchange procedure? Not related to the dizziness. I was kind of curious where with the language and time and difficulty with those concepts, I'm curious, is it a potential residual effect from the stroke affecting her cognitive function, or is it just a language barrier? And she's so gung-ho on being independent and not wanting to use the interpreter. Is that potentially interfering with her understanding and whatnot of that information? And then you briefly casually talked about the brother and the father saying how she was actually happy that they left, but I would almost want to dive deeper because we know that any type of trauma, and it doesn't have to be a big trauma, it could just be subtle things throughout our life, can manifest physically if it's not addressed. That I don't necessarily think that's the cause of her dizziness, but just since you did mention it, I would, if you do have the support on your team, I would just make sure that we're really supporting all angles of her health, because we know that there's so many things that can cause these vague, non-specific symptoms. But I would think about what she's doing leading up to the exchange and just make sure she's eating, she's hydrated. I think you did everything appropriate with the medications. And then you could always just consider if this is a repeating thing, just a small fluid bolus with the exchange and see, does that potentially counteract those symptoms?
Right. She does get a bolus. I don't know the timing of it, if it's done afterwards to support her. I tried to encourage her to take PO fluids because she can. But I wonder if that's just not either fast enough or good enough.
We did that too in this patient. Yeah, this patient of ours, she just both times she would end up in the emergency room. So now I kind of don't even give the option because we found adding that fluid bolus was something that's going to help prevent these orthostatic episodes. We still do. I totally agree. We should push oral fluids as opposed to just relying on the IV fluids. But at the same time, 500 cc, especially if they have good kidney function, it didn't seem anything suggestive on here that there's a concern with her fluid balance, but she more than likely would just process and hopefully
Yeah.
preventive
Yeah.
for future episodes.
Right. I mean, right.
Has anybody else seen something like this on the call? Any patients who've presented with a similar orthostatic or dizzy episode with or after the exchange procedures? And how did you guys manage that? And there's no right or wrong answer. This is a very non-threatening echo session. So anybody, please feel free to go off mute, go off camera. Otherwise, I can continue to fill the air. I'm really good at this. No, I'm kidding. And Kirsten, if you wanted to email me offline, I can always connect you with our phoresis team as well in case they have any further insights that we might not be
Great. That would
thinking
be,
of as
that would be,
obvious.
that would be, that would be
I'll
lovely.
send you a separate email afterwards, just in case there's something else
Yeah.
that we might be looking at.
Did you have to use any medications to for that one? Oh, she actually transitioned after she started her apheresis.
No, she actually transitioned. I'm an adult provider, so any patient who comes to us on simple transfusions will almost always transition them to exchanges. So we had transitioned her from pediatric to adults from simple transfusion to exchange. So it was already a hard transition. And then on top of it, we're switching your whole regimen. So there was some anxiety inducing stressors associated with that, which manifested with certain physical symptoms. But then when we addressed that and did the numbing cream and same thing, having the same nurse and made the process a little bit more manageable, the dizziness persisted and she had it seemed like a vasovagal response, but regardless, the fluid bolus was something that managed. But I'll send an email and we can connect offline and just see if there's anything else creative solution from that standpoint from our team.
Sounds good. Thank you.
Awesome. Well, I'm very excited for our next presenter. Let me pull up his bio because my memory is not that good. But we have Mr. Amir Alghali. He is a master's in science of nursing, nurse practitioner, or family nurse practitioner, I should say, specializing in sickle cell at the University of Maryland Medical Center outpatient sickle cell team. He has a bachelor's of science in nursing from Towson University and a master's of science of nursing from Simmons University. And he has almost 10 years of experience and he's worked across multiple healthcare settings, including private pediatric care and sickle cell clinics at both University of Maryland and at Johns Hopkins. Now, this is my favorite part, so thank you so much for disclosing this. But as a person living with sickle cell himself, he really has a true commitment to the community and a passion for improving care and outcomes for people with sickle cell disease. He enjoys building relationships with his patients as well as providing a holistic and integrative approach to healthcare. So you are speaking my language completely. So I'm very excited to have you today on this presentation on transitioning. Sonia, do you want to share your screen? Do you have it up? Okay, awesome.
All right, good morning, everybody. Thank you, Maya, for the introduction. Can you guys hear me okay? Okay. All right, so this is my presentation about transition to adult care in our sickle cell disease population. Next slide, please. Thank you. I have no disclosures. So the objective today, we're going to describe the process of healthcare transition program for emerging adults with sickle cell disease. We're going to review the current transition models and interventions that support successful outcomes. And we're going to recognize the best practices and team roles in facilitating transition to adult care. So let's begin. What is healthcare transition? Healthcare transition is a purposeful, planned process of moving from child family-centered care to adult patient-centered care. Involves the planning, transfer, and integration into adult healthcare. American Society of Hematology states that transition includes readiness assessments, medical summaries, and structured communication between pediatric and adult teams. And our National Alliance of Sickle Cell Centers state that a successful transfer is greater than or equal to 2 visits with a comprehensive adult sickle cell program in the first year. Could be either in-person or telemedicine. And they further define that a successful integration is greater than or equal to 50% completion of scheduled outpatient visits annually in the 5 years after transfer. Next slide, please. Thank you. So why does transition matter? As we all know, sickle cell disease is a complex and challenging lifelong condition to manage. Many youth are unprepared for adult care. They may not know their medical history, their medications, their insurance details, or even how to schedule appointments. Transition gaps, as you all may be aware, can lead to poor outcomes, including missed care, increased emergency department visits, and emotional distress. Adolescents often feel overwhelmed or abandoned once they leave pediatric care, and mortality peaks around this age, between ages 20 and 24 in sickle cell disease, and most deaths occur within 2 years after transition. It's very costly. It's estimated at $45 billion annually in the U.S. For poor transition outcomes. So here are the goals of healthcare transition. On the left is the patient level goal, which is just pretty much building skills, knowledge, and confidence to utilize the healthcare system and take ownership of their care. And then on the right is a system level goal, which, the system needs a structured, coordinated process between pediatric and adult teams to help these young adults establish care. Next slide, please. And then, so here's the barriers to healthcare transition. So on the left, we have system barriers. As you see, lack of specialized and interested providers, lack of care coordination across pediatric and adult health systems, and losses in health coverage. There are patient barriers too as well, which could be deficits in cognitive function, lack of preparedness, and additional health comorbidities. And then there is stakeholders perception. So pretty much patients may be less likely to engage with the adult system due to the poor experiences they maybe receive in the ED or unsatisfactory working relationships with adult providers. So that will lead them to manage their pain disease complications at home and delaying necessary care. So all these barriers can cause issues for our young adults transitioning. So we just want to be mindful of them. So here are some differences between pediatrics and adult sickle cell care. As I mentioned earlier, pediatrics is more family-centered. Parents are heavily involved in the care decisions. They make collaboratively with family. Caregivers often access their health information. The parents most of the time do care coordination for them. And in our pediatric setting, usually planning starts early, around ages 12 to 14, with structured readiness assessments. And you see on the adult side, it's a little flipped. It's more patient-centered, more autonomy and self-management expected. Patients expected to coordinate their own care with limited system navigation helps. Hopefully your healthcare systems have maybe a nurse navigator in place or a social worker that can help with these things. Health information is private unless the patient grants access. And the expectation of full readiness is expected by transfer. Adult providers assume baseline competence. All right, so here you can see a timeline when our pediatric colleagues try to prep the patient for transition. This is just a timeline of transition work. So as you can see, at age 12 to 14, they give like a transition policy, a guide to let them know what's going on, then tracking and monitoring. Then there's readiness around age 14 to 18, make sure that they are ready for adult care. Then there's planning at that stage too. And there's transfer of care, 18 to 21. My facility, we transfer around age 22. And transition completion from guide transition says that usually is around 18 to 21. So here you can see this is the framework. So the timeline before the previous slide is different from this slide. This is just a framework. This is the structure. This is what should be happening during transition and integration. So as you see, some similar things: transition care policy guide, tracking and monitoring, orientation to adult practice, integration to adult practice, initial visits, and ongoing care. So here are some tools. So the American Society of Hematology actually provided a readiness assessment that our pediatric colleagues use to identify knowledge, skills, and gaps before transfer. We can look at it if we want. I put the hyperlink there.
You want me to click the hyperlink?
Yes, please.
Okay.
Hopefully it works. And it's okay if it doesn't
Okay.
work.
Yeah.
But
Sorry.
no worries. This is on American Society of Hematology's website. So if you guys want to utilize it, your pediatric colleagues, feel free. It's there for us to use. And then the next section is the medical summary form. So for us, we meet every other month for our pediatric colleagues. And during that meeting, that is 3 months before that young adult comes to see us. And we go over the medical summary form, which tells us the genotype, treatments, complications, care plans, and just promotes continuity of care. And that's also on American Society of Hematology's website. So feel free to use it. It's here for us. So, all right. So let's get to it. So this is the first element is a transition care policy guide. Like I mentioned, the pediatric transition policy was discussed at age 12 to 14 with patient and family. And then we also, from the adult side, we have our transition guidebook or welcome brochure. It usually just outlines care policy, sickle cell healthcare team, patient face sheet, differences between pediatric and adult care, navigating your health, FAQ, frequently asked questions, contact info for referrals, pain management plan, and additional information. And there's our welcome brochure that we utilize at my facility. Just pretty much outlining those things, just so the patients can get that knowledge. And sometimes they're forgetful when they're in a visit, so they have it with them that they can look to.
If you're okay, I'll put these attachments in the follow-up email, if that's okay.
Sure, yeah, that's fine.
Downloading, right? Okay.
All right. So next element is the tracking and monitoring. So this just identifies the process on identifying young adults. Like I said, we do a pediatric handoff. So a pediatric heme team contacts us via email and or plan meeting, summarizing key points of the healthcare summary and provide recommendations as necessary. Our adult MPs meeting happens every other month, with meeting occurring 3 months before young adult transition. We also have a registry. You could develop a registry. Our EMR collects great information, tracks patient demographics, visit attendance, and missed appointments. They can also do research at registries if your facilities are doing research to monitor outcomes, such as acute care utilization and long-term adherence. So orientation to adult practice. So you want to identify, it's very great to identify interested clinicians who like transition. Sometimes some providers don't like transition, and that's okay. So thankfully our team, most of us do transitions. So you see my colleagues there. So pediatric sickle cell team contacts us via email for provider informal visit, or patients on campus to introduce and allow tour of adult space. So sometimes if we're not having clinic, we'll go down and meet those patients so they can see a face and see the adult space too as well. In the welcome and orientation process, our referral office makes contact with the patient before a first hematologist visit, reinforces clinic directions and what to expect, schedule of hematologists within 1 to 3 months. And after that, even our nurse navigator provides follow-up with similar information and sends sickle cell welcome brochure for review. So as you can see, there's multiple reminders. So we want to make sure that we're not having those patients fall through the cracks, because that's when increased mortality happens. So this is our orientation process, and our orientation process that you could maybe model or follow. And most of these transition policies are, adapted from GOT Transition and American Society of Hematology as well. All right, so integration to adult practice. I guess nurse navigator sends welcome email, nurse navigator sends visit reminder phone call, and a hematologist pre-charting and review of pediatric handoff happens. This is probably happening around like 1 to 2 weeks beforehand, before the visit. And then initial visit is with our hematologist, orientation clinic, preferred lab, preferred pharmacy, sickle cell treatment, review of sickle cell treatment, sickle cell pain management, how to get care. If you guys have an infusion center, how to get care in an infusion center, what's the number to call, care partners, if they need care partners. Here are some common ones that we utilize: psychiatry colleagues, ophthalmology, primary care, dental care, other specialists. Notifying the pediatric group that the patient has arrived or was seen. Sometimes the pediatric team knows best how to get in contact with these patients because they know them for so long. So utilizing them even after transition is very helpful. How to follow up with the hematologist, even if it's telemed or in person, and then talking through them with about APPs initial visit as well. So usually after our first hematologist visit, we like to do another APP visit within 1 to 2 months. We like to keep a close eye on these transitioning patients so they don't fall through the cracks. So we answer any concerns or questions that they may have. We follow up on any care partner appointments that they may need. We review their sickle cell treatment, pain management plan, make sure that they're okay with it, and it's based on what they received during acute care utilization, either in the EDs or during admissions. We review our clinic numbers, hours operation for acute treatment, and review they have MyChart access. Also for our young adults, they're very tech savvy, so we like to make sure that they have MyChart because sometimes they won't pick up their phone and they'll rather text or MyChart us. So we make sure that's in place. And yeah, so that's the APP visit that we do, and then just ongoing care. Like I mentioned, we provide acknowledgement to the pediatric team about completion of transfer to adult care. Nurse navigator and social worker assist with possible adult specialists, insurance resources, self-care management information, and community support services. And then we just continue with ongoing management with hematologists and APP at recommended intervals. So here are some notable young adult clinic statistics. Back when I was previously worked at Hopkins, I was in charge of transition there. So from March 2019 to September 2023, 89% of our patients attended the young adult clinic appointments. 97% of patients referred from pediatric sickle cell care attended a young adult clinic appointment, and most patients attended their first scheduled appointment, which was 61%, over 50%. And among rescheduled patients, the mean number of scheduling attempts before attendance was 2.9. And then to the right, as you can see, there's a study done at Boston Medical Center from September 2021, May 2023, with Collaborative Transition Clinic. 18 and 22 of their patients, 82%, attended at least one visit in the transition clinic, although in many cases they required rescheduling after multiple no-shows. Also, 8 of the 10 patients scheduled for initial visit in adult clinic attended the visit within an average of 2.4 months, and that's 80% attendance rate, which for them was a promising initial outcome. So as you can see, these results indicate that healthcare systems designed to meet the needs of young adults in sickle cell enable successful participation into the care. So just shows the importance of establishing a collaborative agreement with your pediatric colleagues as well as adults to maintain these young adults and avoid early mortality. And that is all I have. I'll take any questions.
Thank you so much for this presentation. I feel like when it comes to transition, it's always such an important topic, and just we feel like we know what the best practice and what should be done, yet even knowing that there's still some obstacles and whatnot. I'm curious for you, just having experience as both a warrior and as a provider, like what do you find are the most essential things that are necessary for a successful transition?
Yeah. So going from my case, my parents were definitely heavily involved. And then during transition, my mom was telling me, oh, you got to call this number, you got to call the pharmacy. Like, these are things that I really didn't do per se because I'll be honest, my mom was very heavily involved in my care. And knowing stuff about the pharmacy, when to call, how to do a refills is something that my mom had to tell me over and over again and tell me this is how you do it, this is how you do it. So I think that multiple reminders definitely helps. As a provider side of things, sometimes, we also have to look into their psychoeconomical status on what's going on. I work in Baltimore, so we have a lot of inner city patients coming in, and sometimes they can't even they have no transportation to get to our facility, or there's no electric in their house, or there's no lights on. They have to get there children to school. So there's other factors that involved no-shows, and having our social workers and nurse navigators like communicate with them has been very helpful as well. Sometimes my Hopkins colleagues we were very strong on MOCAs, on initial visits once a year, because sometimes they don't even know how to navigate the healthcare system. And coming from me, who thankfully have good cognitive status, like it still was a learning process, So somebody who has a poor MOCA, I can only imagine the struggle that they're going through to trying to navigate the healthcare system. So using all those factors and keep that in mind, I think that we'll be able to keep our patients into care and not having them fall through the cracks.
I think you made such a good point too, because when we think about all of the things that impact health outcomes, treating the sickle cell disease is just like one teeny tiny bucket when you're missing the whole psychosocial and the economics and the support and their living situation. Like it's so easy to label somebody, oh, they're a no-show, they didn't come to clinic again. But when you get a little bit curious and they realize that they're having to decide, do I miss a day of work and not get paid to go see a doctor? Or like, how am I paying the bills? There's so many different factors that go into play. So I think it's really a great reminder for us as providers to get curious for non-adherence or no-shows and those type of things, because there's different ways for us to potentially help them. Thank you for that. Does anybody else want to ask any questions, comments?
I have a comment. Thank you for presenting the final statistics. They are amazing. 2% to 61%. 81% to rate. Congratulations.
Yes,
That's
thank you.
really, really amazing. And it's it's also reassuring, like hand washing, very sort of simple. We know what we have to do. It saves lives. Transition saves lives. You've proven it, it seems. And it's all outlined in Got Transition. What could be easier?
Yes.
We just have to follow our own rules. Yeah, we all know it's not that easy.
It's not that easy, but yes.
I just actually have a comment. I was listening to your presentation. It was great, by the way. So I'm in adult care, and I'm in Michigan, and we are actually we're the first adult dedicated sickle cell clinic, and we've just started within a year ago. There's always been a children's center, and we've kind of partnered with them to try to transition some of their patients. The problem that I am seeing, we have not successfully been able to transition not one of their patients in a year because they don't want to let go. They have patients that are like 28 years old, and some of these patients have two children, like their moms theirself, and I'm kind of and I have a really good rapport with the nurse practitioner there, but it's just it's without trying to really say in a negative way, this isn't helping them by holding their hand all and the problem is they can't go to the pediatric emergency room either. They're coming to different so they're getting introduced to adult care in the wrong way. And I've tried to say that, but I just feel like they feel like these are my babies and I gotta hold on to them. They're almost as bad as the parents. Yeah, I feel like because I get in retrospect, I will say that they didn't have anywhere to really send them to. But now you do, and we're working together. But I still feel like I'm there's a roadblock between us in getting some of these patients over here. Do you have any suggestions I could take back to them? Because they're in a firm belief is we're not going to use age as a guideline. We're going to let them decide. And I feel like that's not giving them the kind of push that they need to really come into adulthood. I said, their oldest patient is 28.
Yeah, no, that's a great point. And I'm guilty, right? They've spent all this their whole young adult life with their pediatric provider, and now we're telling them to transition. So like I mentioned before, even before they transition, having them see you, a familiar face, informally, that would help with transition. And then also establishing that relationship with your peds colleagues. So during those meetings, hopefully, maybe you guys have those meetings over there in Michigan, when you're meeting with your peds colleagues to discuss these patients, even doing education and just about transition, and look, these are the statistics. And like you mentioned, I think you advocated very well. meeting adult care in the wrong way, and they're getting these negative perceptions, and now they don't want to establish with us. So when you're meeting with those pediatric providers, even maybe just doing a PowerPoint like I just did and saying like, look, these are the transition outcomes, can we really partner to establish these patients to come over, and it's just going to be, one thing I've noticed is it's frequent reminders, and it takes a village, your hematologist
Mhm.
is to get into these conversations. The nurse navigator, the social workers need to get into these conversations. So just, and even if we have a good connection with the ED too as well. So if the ED are seeing patients who haven't specific transition, they can contact us and we can get them scheduled. So having all these providers in different levels and different areas reinforcing the same thing can be very helpful as well. But that would be my advice. It takes time as well. Change takes time. So just keep that in mind. It's not going to be overnight, but with frequent reminders and communication, hopefully, it can get better.
And I think just keeping a good relationship with those doctors, I totally agree. Because I think insurance is usually the ones who will push them to the adult side. So when I get a patient who's between 22 and 24, I know that they're going to be, not to judge, but it's like, I know that they're holding on to some of their faves when that happens. But insurance a lot of times will be the ones to force the shift. So I think you using the approach that meeting the adult team in a hospital setting is not the ideal scenario, and anything that we can do to lighten that. And then you can kind of do like a transition almost, where when we transition our patients, we are trying to sandwich it. So we'll have the last PD hematology appointment, they'll book the adult hematology appointment, and then they'll have another PD appointment after that adult scheduled one. So we're kind of trying to sandwich it. So if they miss or no show that adult appointment, we then have another opportunity to try to catch it. So I think you can kind of stagger some of the visits. So it's adult PD. Granted, it means more visits for the patients, but then it might be just give more comfortability for both the pediatric providers who are just probably understanding what happens when their patients go in the community and are protective and holding on to them really out of the goodness of their heart, because I mean, we know what the realities are, unfortunately. So I think it definitely comes from a good place, but I think the more times you can just instill trust and show that you guys know what you're doing, you care about these patients just as much, and then you really are doing it for the benefit of the patient. Because I totally agree, the ER setting is not that introduction that you want. And I think if they can connect with the primary team, the adult team, then it's going to just make that look very different. Any other questions or comments?
I have a question. How did your mom do with transition? Was it hard for her? I mean, you said she was very involved all along.
Yeah,
How did
yeah.
that transition happen for her?
She understood. I mean, so she's a nurse manager, and I think that's what was key for me in regards to managing my sickle cell growing up. But she was hard because she also didn't. She had trouble letting go, and I'm a mama's boy, so like there was that balance between us. But once she found out, she did want to learn. So at Hopkins, I went through the Hopkins system, and at Hopkins they did a meet and greet with potential adult hematologists, and that was helpful. So she saw the faces and did her research, and once she did her research, she felt okay for me to manage it. And it would give me advice here and there, but it was definitely hard for her to let go too, because our pediatric colleagues do a great job of managing us, and when it's time to transition, it is a scary process. But she was able to. Hopkins also, they reinforce like autonomy. So you know, um, they're able to enforce that as well, and I was able to come in and do the stuff that I needed to do to take care of my health.
And at what age did you perceive necessity? Like, I got to do this? Because at one point, patients have to get to that point. How old were you when that happened?
Probably when I was, I think, the summer of maybe going to college. I was having to drive. I was driving at the time, so yeah, I would drive to my appointments. So my mom would call me like, "Amir, you schedule a hematologist appointment." And I'll go once a year. I have to make sure I get labs. I take hydroxyurea, so I make sure I get labs every so often. There's a lab court next to my college at the time, so just learning a lot of stuff during that time. as I mentioned, I was in college at times. I'm learning college stuff on campus and trying to manage my health stuff too. So it's a lot of things I'm trying to juggle as well. So I can only imagine, some of our sickle cell patients who don't have that liberty or, so it was definitely tough.
Okay.
Yeah.
So definitely once you were in college, maybe like 22, 23?
Yeah. Yeah.
Okay.
Yeah. That got transitioned, I think they said 18 and 21. Definitely around that time, I was starting to be more independent. And definitely as I got to 21, I was well functioning and doing my own thing.
Great. Good job.
Yeah. Thank you.
I think that's awesome. And I think that there's more to you than I don't know where you're at in your journey, but I can see you doing a lot with your professional and personal experience and really transforming a lot of the care in sickle cell. So this is just the
Appreciate
beginning
that.
for you. Thank you so much
Thank
for
you.
everything in the community. And I see a large wave and shift of even our patients and a lot of patients online who are entering in the medical fields, whether that's being an APP or a nurse or a respiratory therapist or social worker, because they want to give back to the community that they serve. And it gets me so excited because it's been a very long uphill battle for centuries, really, for the sickle cell community. And I would say in the last 5 years, we're really starting to see a lot of change. And I think with this new shift of providers and a younger population being raised in hopefully in environments where we just are nice people and treat people with kindness and compassion and don't judge and stigmatize individuals, we're going to finally get the change and the shift that we so desperately need. Any other questions, comments, or feedback for Amir for transitioning or life? Cool. I'm going to do one shameless plug and then I'm going to hand it back to Sonia. So for those who might not be aware, I do have a nonprofit dedicated to sickle cell. It's called Heme Foundation Health Equity Matters. And this year's fundraiser is a coin design contest. And we had 489 people vote for this coin design. And the top 2 designs ended up being created on this 1 ounce silver coin. So it just came in the mail, the sample finally. So the front of the coin is actually by a sickle cell warrior artist named Rizzi Akanji. I'm not sure if you guys have connected with him, but his work, I mean, the work is absolutely gorgeous, but the messages and the meaning behind all of his artwork is truly powerful. And then the back of the coin was designed by an advocate. I believe she has a relative with sickle cell, and she made just something that represented the geographic location and how widespread sickle cell affects across the globe. So the sales will be going on sale this month in honor of World Sickle Cell Day, World Sickle Cell Awareness Month. And all of the proceeds are what allow our initiatives to remain completely free and accessible for sickle cell warriors. So everyone, please use the month to spread awareness and just continue to preach and have the uncomfortable conversation, since ultimately that's what's necessary to really bring the change and care and compassion that we need to our community. Sonia, you want to wrap everything else up?
Yeah, so thanks again, everyone. I'll send out the video from today along with our upcoming session. So thanks again, and I'll put the link in the chat box for the CNP. So if you missed it in the beginning, you can check it out now. Thanks, everyone.
Awesome. Have a great week, everyone. Take care.